they're going to make a determination then of what sort of care they might need right then and there. Do they need an x-ray? Do they need pain medication? Most emergency departments are not going to be providing any anti-anxiety medication. It's not considered within the standard of care, and also within the standard of history taking and forensics for court. If at all possible, we don't want them in any way impaired by something we've given them, because we may get one history in the emergency room, and then when they do a history for law enforcement 2 days later, it may be variable as to what information is still being provided. We're going to look at then doing some sort of a genital examination. Now, always remember that in a medical setting, the patient can decline. I like the word decline rather than refused. But they can decline any or all part of a medical examination. And many people will come in and say, I don't want you to look at me or do a genital exam. I just want antibiotics, emergency contraception, and I want to just make sure that I've documented it. Okay? The other area that comes up with the genital examination is whether or not we're going to use a speculum. And this causes confusion not only within laypersons, but within the professional community. We do not have to use a speculum in order to do a genital and internal examination. So if you are concerned as to a speculum was or wasn't done, please feel free to talk to the nurse. And anytime you do talk to the nurse, please, if you're asking why something wasn't done or that you have some concerns, always do it outside of the patient's room. You want to make certain that it doesn't set up an adversarial relationship, because we do things and don't do things, and often are not going to be relating to you why we made a decision. It's not because we won't, it's just we don't think about it. The other thing is that we're going to collect forensics. There may be what we call adjunct treatment, and that adjunct treatment may be the x-raying of the possibly broken arm, applying a splint, sling, things like that. You're also going to look at standardized sexual assault treatment that we provide, and then we're going to do discharge and referrals. Now that sounds pretty straightforward, but it generally takes a minimum of 2 to 3 hours, and that's the national average is 2 to 3 hours to complete a full forensic evaluation of sexual assault. Now, in the middle of all of this, we're talking about consents. This is another area that causes some sort of concern between often the advocate and nursing and medical. We get initial consent when a person is brought into an emergency room. We officially don't have to have any additional consent beyond that. However, most sexual assault providers will do a separate consent, which also usually includes a release of information for adults as to who we're going to release the information to, who they want us to talk to, and other factors. Another point, though, is that we have implied consent. If somebody comes in and they are unable to consent, we will take care of them in a manner that is appropriate. We will make medical decisions in their place. We will not wait until they wake up or expire in order to start looking at decisions as to what we're going to do. An example of that is a young lady came in, she was 14, and she had been found down on a hiking trail. Her clothing was in disarray, so certainly there was some concern that she might have been sexually assaulted. When the nurse went in and did the initial assessment, in looking at the genitals in order to put in a Foley catheter, which would be a standard for somebody not responsive, she noticed that there was blood. She didn't know if it was period blood. She didn't know if it was trauma blood. We were called in, and we did not wait for her to come out of surgery. We did not wait. She also had a stab wound to the abdomen, hence the surgery. But we didn't wait. We went ahead and gathered initial forensics. We swabbed fingertips. We got identification of defensive wounds that were identifiable on her that may have been altered or contaminated once she hit surgery. So that's implied consent. We did not have her parents at the time that we made those decisions. So we will make medical decisions, and that sometimes causes concern. And again, feel free to talk to the nurse about that. The other thing is that we will get kinship consent. So if a child is brought in by aunt, and I know we're talking about post-pubescent, but remember a teenager is a child, we may have that aunt sign a kinship. Say they're 12 and they're not yet of the age where they can consent on their own. Babysitter brings the child in and is alleging that your boyfriend has touched her. We're not going to call mom and or the boyfriend or stepfather and ask if we can have permission to do a sexual assault examination. The law provides for us to do that without it. We may look at consents for information sharing between advocacy and medical. And again, that would be something that your organization would set up. I can tell you that most, and moving on to HIPAA confidentiality, most hospitals nowadays are going to request some sort of formal business agreement, just meaning that who's assuming what liability. What records are you going to keep? What records are we going to keep? How are you going to share now third-party information that you've gotten from a medical facility? So there's usually some sort of an agreement that goes into place. Many years ago, we would just show up at a hospital because we were called. And so that doesn't exist anymore. Most will ask for some sort of an agreement. And it doesn't have to involve money. In fact, it doesn't with advocacy. If you're providing a contract for something else, it actually may be a contract for money. The other thing to be aware of is that having one of these agreements helps with you in regards to not only your personal liability, but your professional liability. It clearly delineates everybody's roles. It delineates what information and how that information is going to be handled. Now, the most important part of anything is what we call the forensic history. What happened? And this is the most important aspect of the criminal case. When I am testifying, often that is the only thing that I'm asked about, is what did she tell you? Especially if there are no identifiable injuries. The smallest detail may be the most important. It's important to avoid interrupting to either clarify or ask or for any reason whatsoever once that forensic history has started. And that's because whatever I was going to ask or the patient was going to respond with may have been altered, either by the question because we